Good afternoon, everybody. I think we are a little bit left behind by those who are out there on the march. I'm still glad to see so many of you here. I have the pleasure to introduce to you a document that WHO just put together with the help of many collaborators, and I think many of you actually in the room have helped us, and that is the consolidated guidelines on HIV prevention, diagnosis, treatment, and care for key populations. And before I even go into more detail, I would like to take this opportunity to thank everybody who participated. It was really a colossal effort to get the various inputs from various angles, including obviously the academic world, including the implementers, the UN family. But first and foremost, we had significant input, high-quality input, really, from the civil society and the key populations themselves. And that really, I think, makes this document, I believe, so special. And I hope you would agree with me, so relevant for what it is meant to do. And it is obviously meant to inform policies, but also practice, ultimately, on the ground. And I want to specifically thank our co-chairs. None of them are now in the room. They're both here in the conference, but they're in other sessions because we all know Chris Byra is obviously very busy. He was one of the co-chair, and Adiba Kamaruzaman from Malaysia was the other co-chair. And I really also don't want to miss to thank my own team, and Annette Verster has done tremendous work, and Rachel Bagale overall led the process within the group. And I think what was remarkable that we were able to achieve this work in 8 months, which in WHO terms is relatively fast, because we have to go through systematic evidence reviews, guideline groups, etc., then write the whole thing, then have it peer-reviewed. We had 70 people who peer-reviewed. I'm sure some of you are actually in the room, gave us more input before we were able to finalize this. So let me talk a little bit more about what it is. The focus, I think, is fairly clear. It is on men who have sex with men, people in prisons and other closed settings, people who inject drugs, sex workers, transgender populations, with a focus on transgender women. So that is certainly an important element, and certainly also a correction from sometimes previously we lump sort of transgender persons together with MSM, but clearly I think there are many differences, and if that was done in the past, and even WHO sometimes did that, that was obviously inappropriate. What we are also trying to address is the specific needs that adolescents have from these key populations. So you will see in the document that it refers to some of the specificity for younger key populations. Why these 5? I couldn't do it better than Joanne just did. Really, we have up to 50% of new infections are actually happening in key populations globally. And we know in concentrated epidemics, of course, that's not a surprise. In the US, it's 70% is in key populations. In Australia, it's estimated 67%. But we also now have increasing data that this holds in what was previously characterized as generalized epidemics in the sub-Saharan African epidemics. For example, we have data from Ghana, Kenya, where we see it's between 35 and 40% of the new infections that actually occur in these key populations. So that obviously requires a sort of a paradigm shift and also a programmatic adaptation to really see how this would be dealt with in the future. Obviously, what we know is that the key populations have poor or relatively poorer access to HIV and other services. They continue to suffer, I would say universally, at different degrees, admittedly, on the stigma and discrimination. And what is obviously very important, these are health sector guidelines, that this discrimination also pertains in health facilities itself. Health workers also belong to societies, and where you have discriminatory norms and stigmatizing attitudes towards key population, these health workers obviously are not spared unless they get special attention, special training, special sensitization, of course. In this conference, and I'm glad there has been a lot of attention also to sort of what we would want to call the more enabling environment, and really the need to review laws and policies in countries to get rid of punitive laws and really create a legal environment that is not hostile but rather permissive to deliver these interventions that we are recommending. It's also clear that there's behaviors overlap. There's men who have sex with men or who may sell sex. There's persons who inject drugs who also may sell sex, etc. Joanne has given an example where obviously transgender that are often included from other jobs basically because they are so discriminated, they end up doing sex work. So that has to be recognized, and we're also trying to account for this in the document. So why consolidated key population guidelines? And what do we mean by consolidation? You're probably aware that WHO has, in the past years, developed population-specific guidelines. MSM guidelines, sex worker guidelines, IDU guidelines, etc. But really, we feel, particularly in settings where there are different key populations, it would have made sense to consolidate across those populations and really to look at what are some of the features that cut across from a programming, from a service perspective, but also maintain the specificity that is required in terms of the packages of interventions that are needed for the various key populations. We also recognize that in previous guidelines specifically, we hadn't addressed, for example, transgender, and clearly that's why we give a strong focus in this document. The way we organize the document, as we are with other guidelines like the ARV guidelines that were launched last year, is to look at along the continuum of care, basically looking at prevention, access to testing, diagnosis if you wish, linkage to other services, to treatment, and really also describe what would constitute comprehensive care, holistic approaches to care that addresses the range of needs that key populations need. Most of them obviously with a direct relationship to HIV prevention or treatment. Another aspect of consolidation is that we are not just listing or describing the what's. In other words, the clinical interventions, what needs to be delivered, but that we really also are trying to say, how can services be better delivered, and particularly for key population, where we know they have poor access to services, we have to even give it more thoughts to say, well, how can we strengthen these services? How can we make them more responsive to the needs of key populations? But also, how can we complement them through possibly other service arrangements, such as outreach, etc. And the third element is how to decide, how to prioritize, how to sequence possibly, but also how to look at quality and performance overall through our monitoring and evaluation efforts. So these are the three elements, the what's, the what to do's, and the how to decides. I'm not going to walk you through the whole list, the scary list that you have here in front of you, but just to highlight basically two aspects. One is, you see the blocks, as I said, the continuum of care that goes from prevention or to testing, to issues of sexual and reproductive health, treatment, ARV-related prevention. It speaks very much to harm reductions, which is not new, but obviously reinforces it here, and also very much to co-infections and comorbidities. And here talking about tuberculosis, but obviously now also new about viral hepatitis, because we haven't had viral hepatitis guidelines before. And then you see that's the one element. And then you see the color code. The color code basically says the black is the recommendations that have been made before. This is not new. The, what is that? Purple, basically new recommendations. And the yellow are recommendations that are in there, but there is still some work ongoing within WHO to refine those. For example, in viral hepatitis, we have now hepatitis C guidelines, but we're still working on hepatitis B guidelines. And we know there's a lot of overlap between HIV and co-infection between HIV and hepatitis. So let me just highlight then what are the new recommendations. One is PrEP in MSM. PrEP means standing for pre-exposure prophylaxis. And the recommendation is to offer men who have sex with men to consider taking PrEP as an additional prevention option. When we launched those guidelines last week in Friday in Geneva, that was actually, it's 2 weeks now already. Before we came here, we got a lot of media attention to the guidelines. Unfortunately, and you may have seen that, there was very much a focus on this one recommendation to the detriment of a better description of the wealth and the richness that actually the guidelines offer. And also there was some misinterpretation of the recommendation. You may have seen the headline that said, WHO urges all gay men to take drugs every day now. That's obviously not what this recommendation is. It is meant to be an additional option for men to decide if that is the right thing to do. It's also not meant to replace other prevention options such as condom use. So clearly I would really ask you to help to convey the message whenever you hear that this is sort of somewhat misconstrued. The other very important area that hadn't been addressed in any recommendations previously in WHO was a community-based distribution of naloxone to avoid opioid overdosing. And you probably are aware worldwide there's a lot of people dying because of overdosing. There's an estimated number of something like 70,000 people who die. And many of these deaths would be very easily avoidable if naloxone, which is an antidote to opioids, would be delivered relatively quickly. And what is new here is that it could be delivered at the community level. Whoever is with the person who overdosed, whether it's a peer or it's a family member, etc., etc. There's this tragic anecdote that just somebody mentioned, I think yesterday in a session, saying, well, you know, there's a father who was in the ambulance with his son who had overdosed, who died in the ambulance, and his son could have been saved if only he would have had naloxone. It's easy to administer. It can be subcutaneous. It can be intranasal. It can be in different ways. So clearly, this is quite, I believe, a revolutionary new recommendation, and with the hope and the expectations that it would really help to save many lives. There's also some recommendations to be further elaborated on HIV and contraceptions, and also on drug interactions. So, the other very important element that's being addressed in the guidelines is broadly described as critical enablers. Oops, I have to scale up, speed up a bit. And here, specifically four areas: laws and policies, the whole notion of stigma and discrimination, the whole notion of empowering the community to participate and in service delivery and in many ways, in program planning. And then also the notion of violence against key populations. And I didn't hear you talk about it much, Joanne, but the violence that basically all key populations in different contexts and different types of violence experience is quite tremendous. But there's hate killings, among MSM in parts of the world, transgender in Latin America. There are statistics that are just mind-boggling, So really, it's about prevention of violence and dealing with violence. Just to give you two examples, in terms of laws and policies, the recommendation is to move, for countries, to move towards decriminalizing the behavior of key populations. And that obviously includes drug use, sex work, and consensual sex among males. And to give you an example, in Portugal, between 2000 and 2008, the number of new cases significantly dropped, and you see the numbers, after the decriminalization of possession of drugs. And obviously, this is a very controversial issue, and it's one, again, that can be misconstrued easily, where it says, oh, now WHO legalizes drugs and drug trafficking, etc. Of course, that's not the case. It's about the behavior that we ask countries to really examine their laws towards decriminalization. And then the other area, I sort of alluded to it already. It's really training and sensitization of health workers, and there's an important example from South Africa that is there. My last slide. So, 3 messages I would like to convey here. There's a lot of talk about ending the AIDS epidemic, and I'm pretty sure we all share the conviction, the commitment, the vision that this is something we want to move towards and it can be done. But I would really like to argue, unless we get very serious in our focus on key populations, remove those barriers that we have been talking about, provide adequate services to them as is proposed in these guidelines, we are not going to get there. The guidelines themselves are just basically a cookbook on what needs to be done and how can it be done. They are not the end in itself, and they are not the solution in itself, but we see them as an important trigger of change, both at the global level, where a lot of this conversation happens, but primarily also at the national level, for policy changes, but also for changes of practice and implementation, because it has this element of how to implement, obviously. And the last message is nobody can do it alone. I think it's an obvious thing. But at the country level, clearly ministries of health and the health sector will continue to have an important role to play, even though sometimes this is difficult and not always it is happening, specifically with respect to key populations. But we cannot let go. We cannot let them off the hook. But it will be done better, and it will certainly be done more effectively if it's done in conjunction with key population-led community organizations. And I believe this is certainly an important ingredient for success in the medium and long term. Thank you very much.